Hi, I'm Rihanna. I'm 26 years old. I'm from Philadelphia, and the first time I took an opioid was when I was 19 years old with my friends. We're going to someone's house to go drink and everything, so we went, and one of them had pink Percocets from her mom or something, which is messed up. I was nervous going in to talk to the doctors the first time because I didn't know what to expect, how they would treat me, what if I was like using when I went in, or what if I have to use before I go, and then, just all of these like thoughts and worries about what the doctor would be like. I feel like, well, this doctor is telling me that this is how it's done and I can't do that, so when will I ever get relief? When will I ever be able to get sober, get clean?
Alex Selby. I work in Brooklyn, New York. I'm originally from Seattle, Washington, and I'm an ER doctor in Brooklyn. I've caught myself multiple times where, you kind of have to turn a switch and say, no, you know what? This patient deserves my care. I can't just keep on saying one more thing is more important, one more thing is more important. This person maybe is less grateful for my care, or maybe has the stigma around them of OUD, and it's easy to put them aside. You're going to have patients come in who are not grateful, who you wouldn't be the first person that you would want to reach out and touch. And I think that that's the trap that a lot of physicians fall into. It's a catch-22 that they're the easiest to do the minimum for, but they're really the ones that need it most oftentimes.
My name is Reynaldo Lopez. I'm from the Bronx, New York. I'm 51 years old, and the first time I used an opioid was when I was 47 years old. It was a work-related incident. I was scratched on the left side of my body. As a result, I became infected with something called necrotizing fasciitis. Thankfully, the doctors and the health professionals there, they were able to save my life. So I was very fortunate to make it out of there, and they gave me a lot of hope. They gave me a lot of inspiration, and their care was unbelievable. When I was discharged from the hospital, I was given a prescription, and I became physically dependent on this medication. I didn't have any money, and I was up for a couple of days, and I was exhausted, and I was hungry, and I was tired, and I couldn't take it anymore. I was crying, I missed my family, I missed my life, and I just needed help, and I tried to get help. I was begging the hospital for help. I needed help from a professional. There was no one else there to help me.
My name is Christine Torres Lockhart. I'm originally from Los Lunas, New Mexico, and I'm a general internist and addiction medicine doctor. I always tell my patients there's inherent in our relationship a power differential, that I always sort of open things of, if I say something that doesn't feel right or doesn't sound right, please let me know. So even though there's that differential, I try to level the playing field as much as I can, but I know I still make mistakes all the time, and I catch myself and I apologize, and patients are incredibly, incredibly forgiving when they feel like you care. So we had this gentleman who came into the hospital with these repeated overdoses and was just not interested in treatment. And I recognized in myself, I was getting frustrated with this conversation. I had noticed that in myself, and I was like, oh my God, what am I bringing to this conversation here? And recognizing, my agenda for what I wanted to get out of that conversation was very different than what his agenda was. And that difference was resulting in a lot of conflict that I was bringing to the table.
And now coming to the hospital for medical care for the opioid disorder, the differences are astronomical. I felt as if I was not a citizen. I felt like as if I was treated like if I was some type of a person that wasn't deserving of care. That's the most humiliating process that I've experienced in my 50 years on this planet. You have expectations to be treated like everyone else.
My name is Seisha von Stephenhoven Brown. I'm 28 years old, and the first time I used opiates, I was 16. Until white doctors, whether it be male or female, start taking people like me seriously, there's not gonna be any help for us. When I was hit by this car, I was in a coma for 3 days, and I needed to go to physical therapy, need to learn to walk again. I was prescribed opiates for my pain because it was tremendous. And still, I am an addict, but I have to take this for my pain. So it's more like, it's kind of like a double-edged sword as a Black queer woman. As a Black woman in general, often not heard. So if a white cis male goes in the doctor's office and is just like, I'm in pain, whatever the case may be, they're taken seriously, no questions asked. If I go into a doctor's office with any type of pain, 9 times out of 10, it's going to be, well, you just want drugs. No, I don't want drugs. I have a history of chronic pain, and I don't want to be in pain. The issue is they don't see us as people. They don't see addicts as people. They just see us as addicts, and that's not the case. I am more than my addiction.
My name's Sathaji Kadharesu Nageshwaran. I currently work in New York, having grown up in London, and I'm a neurology resident. I see OUD patients frequently. I work in a central Manhattan hospital, several times a week there would be patients that would come into clinic that had an opioid use disorder. And before hearing them out, I was very sort of suspect that whatever ailment they had would lead them to subsequently ask for some form of pain relief. And having made that decision before a patient enters the clinic, you're set up to not provide them good care and be prejudiced in the care you provide.
It's a prejudice that I think a lot of people have, and I myself am guilty of it. And so it's really important to recognize, I think, first that exists, and maybe you do have that. And then from there, once you recognize it, you can actually say, okay, how do I implement my practice so that I can fix this? It takes a conscious effort, and it's really important.
When I had to go to detox, I definitely was afraid of what that would be like, and put that off for, as a couple days or a couple weeks, or just because, I didn't know what to expect, or afterwards I did know what to expect, and then I really didn't want to go.
Once you identify as a person that needs a detox for opioid disorder, immediately the security guards start watching you. If you're sitting in a certain area, if you go into the bathroom, they're gonna bang on the door. They'll call you by your name and say, such and such, detox, go to window 2. So right there, your confidentiality is broken.
At first, yes, I did keep my addiction a secret because there's a lot of stigma against people who have opiate addictions. I've lost countless friends to addiction. It's heartbreaking because these people felt stigmatized and didn't reach out or didn't know how to reach out, so they were alone throughout this whole process.
I have a patient who, he's been really stable in treatment with methadone for many, many, many years. So stable on his regimen, and he had really terrible osteoarthritis of the knee and was going in for a knee surgery. And so oftentimes when you have these sort of pre-op assessments, you sort of disclose to the anesthesiologist, the surgeon, all the medications you're on, and in particular, if you're on anything like opioids or other controlled substances, just because it affects how anesthesia should be used. But because he has experienced so much stigma disclosing his methadone use in healthcare settings, he actually never disclosed it to his surgery provider or anyone who cared for him in the hospital, and he just went into withdrawal and had a really negative experience just because he was afraid of telling people he was on an FDA-approved medication for opioid use disorder.
Not doing a thorough workup is a very bad disservice to your patients. If someone came in complaining of chest pain or abdominal pain, you wouldn't just cast them aside. The stigma ends up having very negative, real consequences in people's healthcare. And I think that that's the sad reality for many people with opiate use disorder, is that they have been told no so many times. They've been given poor treatment, to be honest, by the medical community so many times that they say, the hospital is not the place for me. And that shouldn't be the case for anyone. The ultimate, worst case scenario for many of these people is they never seek and they never get the medical help that they need. And the sad reality is the deaths of thousands of Americans that we've had.
I spend an inordinate amount of time on the phone with pharmacies, insurance companies, patients, coordinating at times just so someone doesn't have a lapse in their, say, Suboxone medication refill, because I feel like the stakes are so high. I feel like we are literally, like, not figuratively, talking about life and death. So if patients miss a refill of their Suboxone, they will go into withdrawal, they will have cravings to use, and they may use.
Worst case scenario, and we see that all across the country, is death. Death and severe disability. And they're not. Worst case scenario makes it seem like it's a sort of an oddity, a rare event. These are very common events.
If I went to a hospital and I was stigmatized or I felt discriminated against, I would just leave. Now I had to go back into the streets and struggle to find ways and means to get the drugs to use to satisfy my physical dependency.
I feel like the individual doctors themselves aren't necessarily to blame. I think, that it is systemic and they have kind of had this knowledge passed on to them, or, developed this, like, I don't want to say hatred, but, developed this, kind of like view that was negative because of, a lack of experience or a lack of knowledge about, what's going on, about addiction, about homelessness, about just all of the kind of, mental health, everything.
I feel like stigma is ingrained in so much of medical training. To this day, I find myself removing stigmatizing language from my old notes that have been copy-pasted forward. So removing terms like abuse in my notes. Oftentimes the medical record is like chock full of stigmatizing language. It tells a narrative that I believe is sometimes helpful for providers to tell, that centers blame on the patient. So patient is non-compliant with medication treatment, is non-adherent. If you ask enough questions and if you ask why enough, you end up getting to a pretty reasonable answer. I didn't take my insulin because I couldn't afford it. My insurance doesn't cover it. It costs $400 a vial. I didn't make the appointment because I had to take care of my 11-year-old son that day and I forgot to reschedule it, or I never made it to that program because I lost my job and I lost my insurance.
So, on a daily basis in our emergency department, it's very busy. I have a dozen patients at any one time that I'm trying to provide care for, and one of my goals in this is obviously providing good care, but also just like trying to keep all the balls in the air at the same time.
Our ability to access empathy as physicians is prevented by excessive work hours we face, the lack of appropriate staffing, and the acuteness of the environment that we're forced to work in. I think these things all bring us from a level of sort of a human understanding to almost a action response kind of understanding, and you can't access empathy in that environment.
Now we need to make a connection with this patient, refer them to the right services, and really show them that we're on their side.
But we call these things soft skills. We don't call them hard skills, and so we spend less time investing in them.
Reflect and don't let a system separate you from your humanity. You might feel that in doing that it makes you a better physician. You will be able to maybe more rapidly make certain diagnoses, more rapidly deal with certain conditions that you see in a hospital, but that separation from your humanity, your ability to feel, will cause harm.
I I had a patient and she was incredibly defensive and is like, what is this about? And it wasn't until we sort of built up a little bit of rapport and I said, I'm really here just to make you comfortable and make sure that you're safe, that she had endorsed, okay, maybe I used heroin when I was 16 years old. And I said, okay, great, so we're getting somewhere. She said, tell me about that, what was that like, who introduced you, when did you stop? And then she sort of just broke down crying and said, I'm so sorry, like, I don't know why I was so defensive earlier, like, yes, I use heroin and I'm just so ashamed of what I've done. And I said, why do you feel that sort of shame? And she's like, no one knows that I use heroin. She had been using heroin for at least 30 years and on a daily basis, and she lived with several of her nieces and nephews who lived with her, adore her, and she was so afraid of them finding out. And so finally we got to discussing her treatment options, and she had never even heard of Suboxone before, and she was interested in it. She started it, and now she's disclosed her opioid use to her family in hopes of keeping her in treatment, keeping her accountable, and supporting her.
I realized that this doctor was treating me differently, that really showed me an interest and showed compassion in me and what I was trying to do. You know, took the time out to sit down and explain things to me and explain to me what the steps I needed to take in order to get stabilized. And I took his advice. You know, I went on a small dosage, and after a while, I lowered the dosage until finally I'm getting ready to get off of it permanently, and I'm grateful. I'm grateful for that person. I'm finished in like another couple of days. Yes.
I tell our trainees, like, yeah, we don't put in central lines, like, we don't do surgeries, we're not surgeons, but we still have a skill set that needs to be honed with time and practice. And our skill set is communication and motivational interviewing. That takes a lot of time and practice to do.
Recovery is love. It is patience. Recovery is not linear. It's a constant thing that you have to work on. I had an endless amount of support, which I know was a privilege for me, which I know a lot of people don't have, from families, from friends, from clinics, from doctors. This doctor actually took that seriously and gave me resources and actually listened to me and actually heard me and saw me.
It was really hard I was doing very well, and my friend was doing very well too, and so this was a really close friend I met in detox, and then he overdosed and passed away, and so that was like just shattered my heart. And then, kind of not really had a revelation, but just kind of came to the conclusion that, like, okay, he would want you to live more than he would want you to get high. And so I realized that, like, that's the path that I need to be on.
I've known people in my personal life who have had OUD, and a couple of them were childhood friends, and in their early adulthood had, I guess, experience with opiates, and that led them down a path where unfortunately they're no longer with us today. It's really been a personal issue for me. When I talk to these patients, something that I do is I just picture them as someone that I know, trying to help a friend.
I have a personal connection with someone in my family that has a dependence disorder. The sheer extent of human suffering that you see doing this job, I don't think you will be prepared for. We need to have empathy at the center of our society, and at the center of medicine. Without that, we're not helping anyone.